Okay, 10:33, let's get started. Good morning again, everyone, and welcome to PD Active's third online speaker forum. Again, my name is Todd Morrish, and I'll be your host and moderator this morning. We sure miss seeing all of our PD Active friends in person, but we hope you are all staying safe and healthy and active and socially engaged. Before I introduce our speaker this morning, Dr. Henderson, just a little bit of housekeeping. First, a plug for our PD Active programs. Besides PD Active's support groups, did you know that PD Active also offers many other classes and programs for people with Parkinson's? There's Tai Chi and yoga and Pilates and meditation, and there's voice and singing and boxing and dance. I've participated in several of these myself, and I can tell you that they are very helpful and very enjoyable. PD Active has embraced this new mode of digital program delivery, and we have made it easy for our members to access these great classes. We're hoping to get more participants into these programs to continue to make it worthwhile for our instructors. So please check out the calendar link in the upper right-hand corner of the pdactive.org homepage. In fact, I will paste that URL into the chat feature of Zoom right now so that you can all see it. There we go. I hope that's helpful. That's the calendar link on the pdactive.org website. Let's see, right now you are all on mute. I'm sorry about that. We have a large group of attendees today, so this will help make for a more fluid presentation without a lot of distractions. Additionally, you will not see other attendees in your Zoom window, so don't feel like you're all alone. You will see Dr. Henderson's thumbnail, mine, and you'll also see a thumbnail for Sue Stein-Black out there, who was also on the PD Active Events Committee with me. Her video is not working right now, so sorry about that, Sue. Dr. Henderson encourages attendees to submit questions when you have them through the course of his presentation. Do this by using the question feature in your Zoom screen. As these come across our screens, Sue and I will try to pose them to Dr. Henderson so that he might be able to answer them in the context of his presentation. We do have, however, reserved some time at the end of the presentation for more Q&A, so do keep the questions coming. Additionally, I will also present you with poll or survey type questions in your Zoom screens related to the content that Dr. Henderson is presenting. Please answer these as quickly as you can. They're not required, by the way, but if you answer them quickly, the doctor can then see the results of those poll questions and speak to them in his presentation. Depending on how many of these poll questions we get popped up, we may save some of your inbound questions through the chat tool for the Q&A session at the end. Important, this webinar will be recorded, so please make note of that. And we will make a copy of Dr. Henderson's presentation available on the pdactive.org website and/or YouTube channel in the next few days. My own small gentle warning for you is that Dr. Henderson's presentation does contain a couple of photographs that are just slightly graphic in nature. We're all talking about, after all, here the brain today, so keep that in mind. If for any reason Dr. Henderson or I get disconnected from this webinar, which I highly doubt, please be patient and do not disconnect or leave the meeting. Let's see, please, let me see where I left off. And do not disconnect or leave the meeting for a few minutes as we try to get reconnected. It is possible that Sue may take over as host, so keep that in mind. Finally, and very importantly, PD Active depends on donations to bring programs like this to our members free of charge, and we remain grateful for your contributions. If you have not yet had a chance to make the suggested registration donation of $10 for the speaker forum, I will paste that link in the chat feature now. Here comes one more link for you in the same chat area. There you go. And now, without further delay, PD Active is pleased to introduce to you Dr. Jaimie Henderson. As you no doubt saw from the webinar invitation, Dr. Henderson's medical qualifications are both lengthy and impressive. Dr. Henderson is a professor of neurosurgery at Stanford University, specializing in PD and DBS, as well as cancer pain, chronic pain, and sciatica. Dr. Henderson, first, a hearty Go Bears welcome to you. And welcome and thank you in advance for taking valuable time out of your weekend to speak to our community today.
Thank you, Todd. I'm really looking forward to it, and I see that we've got an active group of people here already asking lots of very good questions. So the format of this, that what we're going to do is we're going to take about an hour. I'm going to go through mainly DBS, but we're going to talk about a lot of different topics. I'm going to talk about a little bit about a couple of other current potential options for Parkinson's disease, and then I'm going to spend the latter half of the talk discussing some of the many research opportunities that there are as well. So, hopefully at the end of an hour or so, many of the questions that you led off with may be answered, but there will be plenty of time afterwards. And as Todd said, we'll, if there are germane questions throughout the course of the talk, we'll try to get those answered in line so that there's some germane information around there at the time, but we can also spend plenty of time afterwards. So with that, I think we'll go ahead and get started. All right, so hopefully everyone can see my screen okay. You seeing it, Todd?
I'll check. I am, thank you. It's a nice big spread out widescreen, so carry on.
Okay, terrific. Thanks very much. All right, so as Todd mentioned, I'm the John and Jean Bloom Robert and Ruth Halpern Professor in Neurosurgery at Stanford University, and I've been here for 16 years, and have been pursuing Parkinson's disease treatment for my entire career for over 25 years. All right, so I'm going to talk, as I said, about some of the surgical options for Parkinson's. These include a number of different therapies, mainly deep brain stimulation. I'll talk briefly, just one slide about pallidotomy, which is more of a historical treatment, but is still considered something that one might do today. Duopa therapy, which some of you may have heard about, but which I don't have any experience with, as it's not really a brain-related therapy. I'll discuss in fair depth deep brain stimulation. I know that there have been some recent talks on deep brain stimulation, so hopefully I'll add just a slightly different perspective to this as well. Much of the information may be repetitive, hopefully not too much, but I'll introduce you to the technique that I use at Stanford. And then we'll talk about many other potential surgical options that are now in development as research projects. So I think it's an exciting time for the treatment of Parkinson's disease through surgical means. So pallidotomy is a destructive lesion that's performed in the brain with a heated probe. And are you able to see my pointer, Todd? I don't know if you can see the pointer.
I can, yes.
Okay,
your mouse.
Terrific. Okay, that's great. So, this demonstrates a pallidotomy lesion on an MRI scan. So this is an MRI of the brain, showing where that lesion is in the brain. So just sort of this round target lesion that's made by heating a probe that's introduced through a burr hole. So very similar to DBS, with the exception of instead of leaving behind a wire and connecting it to a pacemaker-like device, you actually heat the tip of the probe using radiofrequency heating and destroy a small part of the brain. So this procedure has been done really since the 1950s, but was reintroduced in the 90s after it was actually popularized prior to the introduction of levodopa, when there were really no other treatments for Parkinson's disease. And then as it was discovered that levodopa and other medications produce side effects over time, including dyskinesia, pallidotomy was reintroduced to great effect. So pallidotomy can improve rigidity, dyskinesia, and bradykinesia, can also improve tremor, although often not as much, and is actually quite an effective treatment. It can be done on both sides, although there is an increased risk of cognitive difficulty or other problems with doing bilateral or both-sided pallidotomy. And since we've been using DBS, it's really kind of fallen out of favor. The reason for that being is that once you've done the lesion, you really can't do anything about it. There's no adjustability, there's no reversibility. If you have side effects, then those side effects are permanent. So despite the fact that it's still considered a very effective treatment, and many neurosurgeons have debated whether or not we ought to be reintroducing pallidotomy and doing it more frequently. But in general, because of the safety of DBS, we really often opt for DBS instead. So stay tuned. I'm going to talk later in the talk about a new type of lesioning procedure that's non-invasive that may actually that may show some promise in using techniques like pallidotomy for treatment. So I think pallidotomy is not completely dead, but as I said, rarely performed these days since DBS has been introduced. Duopa therapy, some of you may have heard of. So the idea behind Duopa is that with continued dosing with carbidopa, levodopa, or Sinemet, as we talked about before, side effects develop. So one can begin to get dyskinesias, you can get unpredictable medication response, sudden ons and offs, and what this does is it delivers the Duopa, the carbidopa, levodopa continuously through a tube that's introduced in the stomach. And then that goes into the duodenum, or part of the digestive tract, and delivers this continuously. So the idea here is that it reduces fluctuations in medication levels. So this is another potential option for people who don't want to consider any type of brain surgery. I personally am not, as I said before, I'm not particularly familiar with this, but it is something that your doctor might be able to refer you for if you want more information. Not to me, I don't do these, but there are physicians who know more about this. Okay, so what I'm going to talk about mainly in the first half of this presentation is deep brain stimulation. So the idea with deep brain stimulation, and so maybe before we get started here, I see Todd has put the poll up, so maybe we can answer this right now. So have you, as anyone in the audience, undergone DBS?
So we can give that another 30 seconds to cook along there, Dr. Henderson, and feel free to keep chatting, and we can end the poll in about 30 seconds and see what those results look like.
Okay, sounds good. So is this the poll is blocking the slides?
Folks can be able to grab the top of the poll pop-up window and drag it to the side so they can still see your delivery. Yes.
Okay. All right, so as you're considering that, the idea, of course, behind DBS is that we have this target deep in the brain, which there are a couple of different targets that we use. This happens to be the one called the subthalamic nucleus, and it's called that because it sits beneath the thalamus. So it's about the size of a large lima bean underneath this large relay station area called the thalamus here. And the idea is that we are trying to introduce an electrode to the target point deep inside the brain. So this is a typically sized DBS electrode, 1.25 millimeters in diameter, which is about the size of a large pencil lead. So our job as neurosurgeons is to try to get that electrode deep in the brain through whatever means that we possibly can. All right, so here's the results of our poll. So looks like about a third of you have undergone DBS. That's great. I hope it's going well for you all. It'll be great to hear some, any questions that you may have about ongoing management of the DBS. More than half of you are interested for yourself, and about 10% interested for loved ones, and then 6% perhaps curious but not necessarily interested in the procedure itself. So that's great to know. Okay, so how in the world do we do this? How do we get this tiny little device deep inside the brain with sufficient accuracy into this very small target? Well, this has traditionally been done with something called stereotactic technique. So traditionally, this uses a device called a stereotactic frame, which attaches to the head. Here you can see that there are 4 pins and upright posts that connect a base ring to the skull. Then one undergoes imaging following this in order to determine what the target is in the brain, and then this apparatus is attached to the top, which allows for precise introduction of an electrode into deep targets. This was invented actually before the turn of the 20th century. So in the late 1800s, these devices were invented for animal surgery, but it wasn't until really about the 1940s when X-rays came into wide use that they were able to be applied for human use because of the variability of people with relationship to animals. Animal skulls and brains are pretty pretty uniform, whereas everybody's brain and skull is different. So here's a patient enjoying a head frame application. During my residency, I did quite a few of these, and during my training, and I always just thought that there should be some better way to do this, that you shouldn't have to be able to, you shouldn't need to place this sort of cage on someone's head in order to be able to do the procedure. And so, here's a patient undergoing a typical DBS procedure with the stereotactic frame in place. As you can see, you're locked in one rigid position. You're not able to move. It's fairly claustrophobic. It's sort of like being in a cage inside the operating room. And so I spent a good portion of my early career developing a technique along with some collaborators that allows us to eliminate the stereotactic frame. So this, in my opinion, makes the surgery more comfortable, easier for people to tolerate. You can adjust your position. It has a lot of advantages to the frame technique, in my opinion. I think it's more comfortable for patients. It allows more mobility for us to evaluate. So, for example, we can look at neck movement. We can allow for people to sort of shift position during surgery to remain comfortable, since the operation is often performed awake. And it allows us to decouple the imaging from the surgery, which allows for OR time savings of up to several hours. So we are able to place the markers, and I'll show you how this is done in just a minute, the day before surgery, and then that allows us to spend lots of time planning without the time pressure of an open operating room. So for those of you, so more than half of you have undergone DBS. The question here is, how'd you have it done? Did you have it with the standard stereotactic technique with a head frame? Did you undergo some kind of a frameless operation? So, I do this with a device called the Next Frame, but there's also other frameless systems, including a robotic one. And then is there some other technique that we didn't mention here, or don't you remember? So if you can, as I'll continue on, if you want to take a minute, think about that and answer that question for us.
And I'll lob in here, Dr. Henderson, that one or two folks have mentioned that they've used other. They've selected other in that poll. So if you wouldn't mind, folks that have used a technique other than what we've listed here, maybe put that in the chat window, and we'll bring that up for Dr. Henderson to see in a few minutes.
Yep, there is. It's I might guess that among other might be there's an MRI guided technique that's used that the folks at UCSF pioneered. So that's a separate sort of technique. It's frameless as well, but it's done completely asleep fully inside of an MRI scanner. So that might be
good to know.
All right. So the steps of frameless DBS, here we go. So the majority of people had DBS with the head frame, stereotactic head frame. A couple of people had the frameless technique used, and a couple others. All right, so the steps to performing a frameless DBS include first MRI imaging. So we want to do an image of your brain that allows us to see good tissue definition, to visualize the areas of our targeting. And MRI is the best for this. But the problem with MRI is that it can introduce some distortions because it's a magnetic type of imaging modality. And because of that, there can be warping if there's any changes in the magnetic field, so that what we see on the image doesn't exactly correspond to real life. On the other hand, CT scanning, which uses X-rays, fires straight line X-ray beams through the scalp, skull, and brain, and is an exact representation of reality. So there's no distortion in a CT image. But the problem with CT is that you cannot see the tissue definition as well as you can with an MRI scan. So the solution to this is to combine both of those imaging modalities together. So we do the MRI imaging first in a setting in which it will be the most accurate and most distortion free. We then place markers called fiducials, which are small screws that we place into the skull that are imaged on CT scan. So then we obtain the CT imaging after that. Then we merge those two images together and then plan the operation based on that. And then once all of these preliminary steps are done, then on the day of surgery, there are a number of other steps that we go through. And I'll walk you through these sort of step by step. So fiducial placement, this involves placing 5 small screws in the skull. You can see them here. They're small. We put them in 5 locations around the head. We actually do this just up in the clinic, introduce a little bit of local anesthetic to numb up the area, make a very small incision, and then screw these into the skull. So it takes us about 20 minutes or so. People have compared it to a trip to the dentist where you get some injection, you get some drilling. It's not particularly pleasant, but it's also not terrible. There is some discomfort afterwards. So we usually send people home with some medication because you do go home after this and return in the following morning. So that evening, we'll give you some pain medication, and the idea is that we want you to take that as soon as you feel any discomfort to try to minimize any pain that you might have from these small incisions. But overall, having placed hundreds of stereotactic frames and having done hundreds of these fiducial markers, I find that these are much better tolerated than a stereotactic frame, which really hurts quite a bit when you put it on. So overall, I think this is a kinder, gentler procedure. Interesting story about this patient. She was my very first frameless operation back in 2003 or 2000, I think 2003 at the Cleveland, when I was at the Cleveland Clinic. She had waited for 2 years to have DBS. You can see how her neck is deformed forward like that. She has a kyphosis, a deformity of the spine that wouldn't allow her to be placed in the MRI scanner in a stereotactic frame. So there would have been no way for us to actually do this operation without having the frameless technique available. So she actually did terrific, and later moved out to the Bay Area, completely coincidentally from Cleveland, and then followed up with me once she got out to the Bay Area. So did very well for many, many years after DBS. So once we've obtained that CT scan, then we merge that together with an MRI scan. So what this shows is some of the software that we used. You can see this the white bone that's visible on the CT, and the black bone doesn't show up on MRI scan, but as you can see here, you can get very nice definition of all these different parts of the brain, which you just don't get as much with CT. But the CT, of course, is quite accurate. And here you can see one of those markers showing up on that image. So merging those two together allows us to be very accurate in our targeting. What I then do is to take a whole host of tools that are incorporated into the software package, where we can do things like false color the nucleus regions. So here's that subthalamic nucleus area that I talked about. We can mock up trajectories that go into those areas. We can try out different entry points, different target points to avoid blood vessels and surface features, so that we take the safest possible route to this area and get the best possible targeting. We can use a coordinate-based system so that we can very precisely, on the scale of even tenths of millimeters, adjust our target to exactly what we want it to be. So the great thing about doing this with a frameless technique is that I can do all of this on the evening before surgery. So there's no time pressure with a patient with a stereotactic frame and the clock running on an operating room. I can do all this in a very relaxed way, so that the very first thing the next day, we can simply execute the plan that I've rehearsed the night before. So to me, this is one of the biggest advantages of a frameless technique from a surgeon standpoint, not to mention the advantages from a patient standpoint. Okay. So apologies, there will be a few images during surgery here. As Todd said, if anyone is squeamish, you may want to listen to the descriptions rather than see them. But I think hopefully nothing is, I've tried not to make anything too terrible, but I do want to at least illustrate how this process works. So the next step here is something called registration. So these are these little markers here on the. These are some sort of rubberized bumpers. at one point I placed these on thinking that maybe they would help deflect any forces, but it just turns out that these are just uncomfortable. So we never use these anymore. We just do the little markers like that. This is the CT scan reconstructed in 3 dimensions that shows those same exact locations. And so what we now need to do is we need to tell the computer, which is going to be assisting me during surgery, where each of those spots is. And this is a process called registration. So in order to do the registration, we use a device that looks like this. So this is a probe that has 5 reflective spheres that are attached to it. These are disposable, single use, and extremely uniform. And then the same with a reference that's placed on the head. So all of these spheres are tracked through 3-dimensional space by 2 cameras that are off, behind where we are right now. And so this reference tracks the head if there's any movement. And then this allows us to very precisely localize each of those spots on the head. So this is similar to GPS satellites, where you have 5 different locations that once the computer knows where those are, we can triangulate any position within the brain. Once that registration process is achieved, whenever I move that probe on the patient's head, a virtual probe moves in the computer at the same time. So we've now linked the head and the brain and everything that we'll be doing during the surgery with all of that virtual information that I've used the night before. So those 2 then are exactly linked. That allows us to very precisely choose our entry point and our target point. The next phase of this is a procedure called alignment, where what I now do is I have to say, okay, we've now drilled a hole, we've attached this platform to the head. And what I'm now doing, and you can see this is a picture of me doing this alignment in the operating room, I'm moving that device to exactly match the trajectory that was planned the night before. And to do that, I'm watching the computer screen, playing almost like a video game in order to do this, where the idea, along with this aiming reticle, which all move as a unit, move that around and then place this over the target. So once the aim point precisely hits the target, we lock everything down in place, and then we know that we're taking that exact same trajectory that we had previously planned. And then this is what everything looks like once it's reassembled. So this is a high precision disposable microdrive. As I turn this knob, it advances this stage downward in extremely small increments, less than 1 millimeter at a time. So one complete turn of this dial moves only 0.5 millimeter. So these are very fine gradations so that we can move very carefully down through the brain, listening to the individual brain cells as we go. You can see the cables that are attached here to our recording setup, which is off this way. And this is, again, one of those trackers, so that anytime the patient moves their head around, which they can do freely, then we're completely tracked. So we're always tracked by cameras that know exactly where everything is in the operating room.
So it's highly precise.
The micro recording process.
I'm
sorry, go ahead, Todd.
That's very impressive that we're down to millimeters and micrometers, but it's highly precise then.
Highly precise. In fact, in our preliminary studies that we published, there were a few of them that we published in different journals. The accuracy was at least as good as a stereotactic frame, and actually in most cases much better. So it's a highly accurate method, and I've been extremely happy with it.
Sorry, and you mentioned as you're inserting that probe, you're listening to the brain cells. Can you explain that a little bit more?
Yes, I will. In fact, I'll give you the opportunity to listen along with me, which will be sort of fun. So this tiny little electrode will be introduced into the brain with the objective being to identify the individual brain cells. And you can tell by their different firing patterns. We can identify the subthalamic nucleus, which is the target that I most frequently use, which is very characteristic. We're looking for cells driven by joint movement, which is called the sensory motor territory of the subthalamic nucleus, which shows our optimal target. And we do this, again, if you look at this very tiny structure inside the brain, we're going to an even finer level. We're now going down to the level of the individual brain cells or neurons. and introducing this tiny little electrode very close to those brain cells, and then listening to the output of those cells, which sounds sort of like static or rain on a roof or bacon sizzling or something like that. We do this with the help of a recording system. This is the big analog rack that we've previously used. We've now compressed this into a laptop size that we use during surgery. So it's a laptop with a transmitter that allows all of the team in the operating room to listen over headphones as we do various different test stimulation. So what you're going to see in the next video, I want to introduce it a little bit because it goes by pretty fast, is my colleague, Dr. Helen Bronte-Stewart, who is a neurologist at Stanford, who is a terrific neurophysiologist who helps me in the operating room with all of my cases. What she's doing is we're in a area of the brain called the sensory thalamus. So this is, we're not typically here for Parkinson's, but what this does is it demonstrates how exquisitely we can localize where we are in the brain using this technique. What you'll see is she's using a paintbrush to stimulate the skin of the hand in this particular patient who's undergoing surgery. And what you'll hear is as she stimulates the thumb, you'll hear those brain cells respond. She'll move to other digits and you won't hear the response, but then she'll come back to the thumb and you'll hear the response. So I just want to play that for you because it's pretty neat. So if you hear that, yeah, so just there in the thumb. So it's very exquisitely precise. And we use the same technique in the subthalamic nucleus where we can hear responses to maybe arm movements versus leg movements, wrist, ankle, and then very precisely localize where we are in that brain region. You know, interestingly, we can also hear things like tremor. So we're often encouraged when we hear a cell that responds to tremor like this one does. So here you can see the tremor and the cell's response.
Oh, that's fascinating. So that's the probe in the brain picking up activity at distant parts of the body through cell activity.
Exactly, because the brain, of course, controls those areas. So what we're looking for is those areas that control that movement. And what we can do then is map those areas out. So if we take here's an example of, this is a cross section through that area of the brain. This is the subthalamic nucleus region, and what's marked here are different regions. So this is, for example, arm movement. This is leg movement. So these are the various different joints mapped out across the nucleus. And then we can very precisely determine where we want to put that electrode to try to get the optimum improvement in symptoms.
That's fascinating.
So once we've done that, we lock the electrode in place. I very frequently will do these bilaterally, so both sides at the same time. Personally, I think it's we can usually do two sides of the brain in about 4 to 5 hours. Most patients need both sides done. I know that there are varying different techniques that different surgeons use in terms of staging procedures one side at a time versus both. Personally, if I was going to have surgery done, I wouldn't want to have to come back for a second one. I'd want to have it all done at the same time if possible. And so I try to do that in most circumstances. We do generally stage the second part of the procedure, the placement of the pulse generator or the pacemaker. And that's usually done 1 to 2 weeks later. The procedure itself is pretty tiring. People after surgery are quite tired, and a lot of this is you're awake during the operation. You're not quite sure what's coming next. It's kind of nerve-wracking, to be perfectly honest. Although I would say the vast majority of patients do terrific. They do great. They get through the operation very well. But it's so tiring that if we then go ahead and do general anesthesia right away and put you to sleep afterwards, it can really make it. It can make it so that you can't get out of the hospital as often. People are sleepier. It's harder to sort of get going afterwards. And so that's why I like to stage that second part 1 to 2 weeks later. And then we generally activate the stimulator about a month after the lead implant. And the reason for this is that we want to make sure that any swelling or inflammation or any of the reaction that happens around the implantation site has gone away before we activate it. Because otherwise what will happen is we'll turn it up. We may get a good response, but then symptoms may come back because things are still changing. So if we wait 4 weeks, things are stable, and we know that the programming is going to be take pretty well. So this allows for resolution of that inflammation and tissue reaction. So this is the sort of prior generation Medtronic system. I like this picture because it gives a sense of scale of all the parts of the system together. With the electrode, which you can see here, as I said, it's like the size of a large pencil lead, and then the pulse generator itself. And this is sort of what it looks like. We usually put a single channel or a dual channel pulse generator on one side, and then hook it up to both electrodes. Okay, so with that, I'm going to sort of get into the current generation of DBS systems. Previously, there was really only one manufacturer on the block, and that was Medtronic for quite some time, 20 years. But now there are 3 different manufacturers. I'm going to discuss 2 of them. I personally use both Boston Scientific and Medtronic. There's also Abbott St. Jude, which produces DBS systems, but I haven't used their devices, as I would say these 2 manufacturers have really, have really been the ones that have fulfilled the needs that I've needed for patients. So it's time for another poll question. So for those of you who have undergone DBS, do you recall which technology was used? So did you have a Medtronic stimulator, a Boston Scientific stimulator, an Abbott stimulator, or you don't know or don't remember? I think these are the only 3. I don't think there's another one out there, but if so, it'd be great to hear. I know that if you've had it done in China, the Chinese have their own system, which is, I think, a kind of a knockoff of the Medtronic system, but it's, I guess, quite a bit cheaper to produce. Okay, so go ahead and answer that question as I continue with the presentation. So the Boston Scientific system, this is with comparison. So this is a rechargeable system, the one that I most commonly use. This is a comparison to Medtronic's Activa RC, which is their standard rechargeable system. So it's smaller, has in my opinion, a nicer form factor where there are no edges. It's almost perfectly round. It has about a 15-year battery life, about 10 minutes per day to recharge it. So there's a pretty simple recharging system with a strap that goes around the shoulders that puts the recharger over the device. It beeps it beeps until it finds it. Once you've found it, then it stops beeping, and then it double beeps when it's done. And I usually encourage patients to take about 10 minutes or so per day to recharge it so you don't forget. Okay, so interesting division, almost a third between the different systems. So what this tells me is that, all 3 manufacturers are used. I think there's, they all have good, they all make good systems, and so it's great to see that there's a wide variety of different systems that are in use out there.
And Dr. Henderson, if I can interject a quick question from attendee Douglas, who asks to be clear that wire connecting the brain probe to the unit in the chest is under the skin, correct?
That's correct. Yeah. Once everything's implanted, the whole thing is underneath the skin.
Thank you. Carry on.
Okay, so then just back to talking a little bit about the Boston Scientific system. If for some reason you can't charge it, so if there's a lengthy power outage or if you're on a camping trip or something like that, the battery can last about 3 weeks if you're not able to get to a charger. But it's, as I said, I like to try to recommend that patients do that pretty much every day in order to try to keep it charged. An advantage of the Boston system, aside from this 15-year battery life, is there are individual current sources, which means that you have the ability to steer the stimulation around, which lets you sort of reduce side effects because sometimes if there's current spread to other areas, by steering the current away from that, you can reduce those side effects. There's a wider range of parameters, and you can get an MRI scan up to 1.5 Tesla. So 1.5, there are a lot of 1.5 Tesla. This is the field strength of the magnet out there. But most of the ones at Stanford are 3, and 3 Tesla gives you clearer images, and most places are going to 3 Tesla. So although you can get an MRI, it's a little bit limited with this system. This is what the programming interface looks like. So what this shows is that this is a map of what the electrode looks like. There are 8 contacts. So there's this contact. There are 3 here arranged in a ring, 3 here arranged in a ring, and 1 here. And so that's this lead here. This is an indicator that shows which direction it's pointed if you get an X-ray. So this just demonstrates how you can steer that current in various different directions. And this is the clinician programmer that we use in the clinic that allows us to, adjust how high the current is, how fast it's stimulating, how many cycles per second, the pulse width, etc. And then this is what the patient programmer looks like. Here's the recharger, as I talked about. It's pretty straightforward. The charger itself is wireless. It's got a charging base that it sits on, and then you can put it into the charging collar, which is lightweight and adjustable and allows you to position it over the neurostimulator.
And that's charging through the skin again.
That's correct, all through the skin.
So no USB type connection.
Correct. So so if patients are interested in a non-rechargeable system, my tendency is to go with the Medtronic system. There's a lot of advantages for non-rechargeable in Medtronic. So this is the latest generation called the Percept PC. This is really an exciting device in my opinion. And I'll talk a little bit about the capabilities of it pretty soon, but this allows us to sense brain activity. And so there are a couple of research studies at Stanford that are using devices like this to sort of advance to the next generation, where we're reading out what's happening in the brain and then changing our stimulation based on that, which to me is a really neat concept. Compared to this older battery, this is the new version, has improved battery life. It's, as you can see, somewhat smaller. It's also thinner. It's non-rechargeable, which is both an advantage and a disadvantage. Many people don't want to hassle with recharging. They would rather just have the stimulator on at all times and forget about it. And if that's the goal, then this is the stimulator to go with. I'll talk about the sensing capability in a minute, which is neat, and future ability to do closed loop stimulation, meaning sensing and stimulation. Doesn't do this yet, except in a research environment. But at some point in the future, when we learn more about how this works, this may be sort of the new standard for neurostimulation. And interestingly and importantly, this one is MR conditional up to 3 Tesla. So this is the field strength of the advanced magnets that are used at academic places such as Stanford. And so this allows you a very wide range of MRI imaging possibilities. So this is what the interface for the Medtronic device looks like. So this is again the clinician programmer that we have in the clinic, and then this is the programmer that the patients get to take home with them, which allows you to trigger particular events. So for example, if you took your medication, if you're having dyskinesias, if you did some exercise, you can just hit a button on the interface and the stimulator will record the time that happened. So you can track those events over time and then correlate them with the brain signals. So this is an actual example from one of my patients showing the different bumps in the different frequency ranges and how it changes over time. So this is the low. This is when things are low, and this is when things are high. And you can see that there's this difference in this characteristic, what's called the beta band, which I'll talk about a little bit when we talk about research at the end, that this is considered an important marker of when Parkinson's symptoms are happening. So we may be able to correlate times when you were off your medication, when the beta was high. If you were having dyskinesia, the beta might be low, or there might be other bumps in the frequency range. So this really gives us a lot of leeway in figuring out exactly what's going on in your brain. And then again, this is the patient programmer that gives you all kinds of good information about the battery life, whether the therapy is off or on, and then the ability to both change to different types of groups. So for example, there are patients who sometimes have some speech slurring or some difficulty with speech when the stimulator is on a high setting. So you may want to put it on a lower setting if you want to have a conversation, but if you're walking, you may want it on a higher setting. So there's this ability to have different groups for different things that you want to do. And as we talked about, the ability to mark events. Okay, so that then brings us to outcomes from DBS. So what are the outcomes? Well, in general, the outcomes are very good, I would say. We usually tell people to expect about an 80% reduction in their tremor, about a 70% reduction in their rigidity, about a 55% reduction in akinesia, improvements in gait, and in somewhat in postural stability. So this is a good time, I think, to pause and ask, for those who have undergone DBS, what has been the most meaningful benefit for you? Improved tremor, improved sleep, improved gait, balance, stiffness, aches, cramps, slowness, etc. Cognitive improvements, improvements in writing, micrographia, improvements in facial expression, or mood.
These unfortunately don't match perfectly with your slide there, but there's some good feedback to be gleaned from it, no less.
Yeah, but I think these are all, of course, very practical things that people would like to have helped. So it'd be great to get input on the benefits that you've seen. So while you're answering those questions, we'll talk a little bit about the downsides of DBS, which unfortunately there can be complications. There is about a 1.5% risk of bleeding in the brain. The vast majority of times this is asymptomatic. I've done now probably close to 800 DBS operations in my career. And over that time period, the past 25 years, there have only been a handful of people who have had either permanent, serious neurological problems or death. So, but it does happen, even though it's rare, unfortunately. There's about a 3 to 5% risk of infection. Stimulation side effects are actually fairly common. So, people can have tingling, muscle contractions, double vision, speech difficulties. We can usually program around these, but sometimes you do have to tolerate a side effect in order to get good improvement. And then, finally, here just to talk about some of these common issues to consider during recovery. Most people will be fatigued after this, and that fatigue may last up to several weeks before it gets better. Similarly, confusion. Some people can be confused after surgery. It is a brain operation, and so these things can happen, but thankfully resolve usually over time. Headache, expected, but also expected to improve. This is a big one. Impatience with programming. It can often be challenging to program these systems, and I would say different neurologists have different degrees of familiarity and capability with programming. So oftentimes it's important to be patient and wait for the programs to be dialed in. If you want to, this is a kind of an interesting article. This was published in Wired magazine back in 2007. This is one of my patients actually who wrote about his experience. He was a technical writer at Apple, and it's kind of a no holds barred article actually that talks about both the good and the bad. So I would, I'd certainly recommend anybody who's going to undergo that to read this. All right, so our poll results. The vast majority of people noted improvements in muscular symptoms, as we would expect. So things like stiffness, aches, cramps, slowness, gait, and balance, very common. And tremor, about 17%. So 83% of people with improvements in muscular function and about 17% with improvement in tremor.
And here in your deck now, we've moved on to drawbacks. So I will go ahead and launch the next one right now.
Okay, great.
My polls are about one slide behind you. So
no worries.
Okay, we'll give that a moment to run, but and do continue to tell us about pain management as you go through here. I know a lot of our members are curious about that. So whether it's during the surgery itself or during recovery, how do you help patients manage through pain?
Yeah, I think this is probably a good spot to talk about that. So in general, pain management during the recovery period, I would say the vast majority of patients have very little problem with postoperative pain. I've had a lot of patients tell me they didn't even take any pain medicine after surgery. Now, I've also had some patients who have had continued discomfort around parts of the system. And one patient, although it wasn't a Parkinson's patient, who had persistent pain to the point where it required us to take the system out. So it really runs the gamut between people who have very little pain and people who have some persistent pain. In terms of pain control during the surgical portions of the procedure, during the very first part where we put the markers in, we inject all of these areas with local anesthetic, and we make sure that they're numb before we begin. So we try to do as good as we can a job of pain control there. During surgery, we also use lots and lots of local anesthetic. We make you sleepy for the initial part and the latter part of the procedure. The second part is done under general anesthetic. So, and at all steps of the process, we try to use whatever medications and other means that we can in order to try to mitigate any pain issues. So hopefully, Todd, that helps address those problems.
It does. Thank you. Thank you very much. And I've just gone ahead and ended that last drawbacks poll. So
okay. So yeah, so lots of different ones. Pain or discomfort during surgery, pain or discomfort during recovery. This one, this lack of improvement or minimal improvement is, that is a little surprising to me. I just among my patient population, I know that most people have some improvement, and so so there are a number of reasons why that could happen. Whether it could have to do with the electrode targeting, that it may not be in an optimal location. It could have to do with programming, where the programming hasn't been optimized as best as it can. And it could be that you may not have Parkinson's. So Parkinson's disease can look like a lot of other things, and it's really idiopathic Parkinson's disease that this is effective for. So it's certainly worth exploring that further as to whether there might be ways to improve your outcome from surgery.
And might it be a function of timing? In other words, how soon after surgery are patients likely to see and feel?
It really varies. Some patients may see improvements right away. Other patients, it could take up to 6 months. So that's my admonishment to be patient with programming, I think is important.
Got it.
Okay, so yeah, that's very helpful. But probably the best way to talk about this is just to let you follow along with one of my patients to see what his experience was with surgery. So I'm going to run this little 5 or 6 minute video that goes through that process.
I was first diagnosed with Parkinson's in May of 1995. It just overtakes you. Everything revolves around my Parkinson's, it seems.
In this home video, Art Davis documents what had become a daily struggle with Parkinson's disease. He is 57 years old, but the effects of the disease had reduced him to a state of near infancy. Some days he was barely able to move, or there were the moments when his body was plagued by uncontrollable, erratic movements. He never knew which to expect. Medication no longer helped much. The only certainty in Art's life was that the symptoms of the disease were getting worse.
Which one we're going to?
Left door on the right.
It's 6 o'clock in the morning, and Art is facing hours of surgery. He is off medication and barely able to move.
I hope to be able to do things that I haven't been able to do. This disease has just consumed me over the last 8 months. The first few years, I was in control. But for the last year, it's been in control.
A couple of hours later, a team of surgeons are hoping to give Art some of that control back by working deep inside his brain. They begin by isolating the area in the brain responsible for the onset of Parkinson's. Art is awake for almost the entart procedure. The brain feels no pain. The surgeons have found the spot now where they need to be. They implant an electrode which will deliver a continuous electrical impulse to Art's brain and inexplicably ease his symptoms.
Let's go to 2 volts.
They experiment with a small amount of current in the operating room. Art is given some instructions to see if the stimulation has any impact.
Close and open. Close all the way and open. Fast as you can.
Look how, that's fantastic. Very good. Fantastic. Good.
Tap your finger like this. Big and wide now. Big and wide.
Could you do that before when you're off?
No.
The surgeons feel good about the way things are going so far, and so does Art. The nurses put his wife on the phone to hear the good news.
Having some good results. We're having real good results. I'll be able to chase you around the yard.
That's good. Good. That's great.
The team's spirits are high, but the outcome is still uncertain. Once the surgery is complete, Art will spend the night in the ICU to make sure there are no complications. A few more rounds of surgery will complete the implant. And we are back. With me here tonight is Dr. Jaimie Henderson, who we just saw at the other end of a piece of scientific equipment. And we are happy as well to say with us here tonight is Mr. Art Davis. Got some complaints for chasing your wife around the yard. When you look at that piece of videotape, that's you, and yet it must feel like an out-of-body experience.
Yes.
What does it feel like now, knowing that was still you then, that you had absolutely no control over your musculature?
I feel 20 years younger. I've not had one bad moment since I've had the surgery.
All right, so so Art, as you saw, did very well, and I would say the majority of patients do very well with surgery. And again, if you haven't had a response, it's worth really looking into why that might not be.
That's a great story.
Okay, so we'll shift gears now a little bit into the sort of more future-looking part of the talk. The first thing I'd like to mention is something that we're doing now for the treatment of tremor, but we're expanding it to the treatment of Parkinson's. So we are looking at research protocols to potentially use this in lieu of pallidotomy. So this is a technique called MR-guided high-intensity focused ultrasound. And so here's an example of a patient who with a disorder called essential tremor, in which he doesn't have Parkinson's, but what he does have is this action tremor, which is extremely severe. So he's unable to eat or drink or dress himself. He needs help with almost all of his activities of daily living. And so he's going to undergo this procedure in which his head is placed into this transducer. So this has about 1,000 sources of ultrasound in it. So there's a membrane that encloses the head. This entire area is filled with water. And here are all the different ultrasound transducers that fire beams of ultrasound down through the skull, through the brain, and to a focal spot deep inside the brain, and does exactly the same thing as what we were doing with our pallidotomy. So it heats that region and burns it and essentially destroys the cells that are causing the abnormal symptoms. It's neat because we can do this, of course, with people awake. We can do it in real time. We can watch as that lesion is being made, because the MRI is able to record temperature, so we can actually see exactly what we're doing, which is pretty neat. And here's the results. So here he is immediately after the procedure. The head frame's been taken off, and had he tried to do this, he would have given himself a shower before. There's no possible way he could have had a drink of water. So this we think this is a really promising technique. We've been doing it at Stanford now for almost a decade. We were involved in the original trials that gained FDA approval for this for essential tremor. And so we're really looking forward to potentially moving forward with this as a treatment for Parkinson's disease. So time will tell whether it actually works or not, but it's very attractive in that it's a non-invasive outpatient procedure, which is pretty neat. Okay, so now I'd like to talk a little bit about some of the many research studies and clinical trials that are out there. I'm just going to go pretty quickly and briefly through a lot of these. There are some that are available here in the Bay Area. There are others that are being done elsewhere in the country or in the world. The first one I'd like to talk about is this AAV-AADC gene therapy treatment. So gene therapy is where virus vectors are injected into the brain, and those virus vectors carry genes for various different types of substances. Okay, so quick question on participating in DBS research studies. We'll be talking a little bit about some DBS studies later. Right now, I'm going to talk a little bit about all of these other types of studies. But if you'd be interested, certainly answer this yes or no, and hopefully we'll get good participation. And I know that many patients are interested in participating in some form of research study. Okay, but this particular study sponsored by Neurocrine Biosciences or Voyager Therapeutics. So these are pharmaceutical companies that are looking into this gene therapy protocol. And the idea here is that there's introduction of an enzyme that increases endogenous dopamine. Well, what does that mean? It means that the dopamine that's in the brain that has been reduced due to the Parkinson's disease is increased. And I'll show a little video that's put out by Voyager Therapeutics that illustrates this in more detail. It's a randomized trial that involves sham surgery. So half the patients will get an operation where they have a skin incision, they have a hole partially drilled through the skull, but they don't have anything introduced. And the reason for this is to try to make it completely blinded so nobody knows whether or not they got the treatment or not, so that the placebo effect, which can be very strong in Parkinson's, can be eliminated. This study is enrolling through 2022, and it involves some of the UC schools. We're not doing this particular study at Stanford, but we are looking to do yet another gene therapy trial. I think many of these are quite promising. So what is gene therapy? So Parkinson's disease, as you know, is caused by the degeneration of the cells in the substantia nigra that provide dopamine to an area called the striatum. So, here's our little yellow dopamine molecules. Keep in mind the shape and the color of these things, as you'll see them in the video moving forward. So the projections from the substantia nigra to the striatum have these terminals. These are the ends of the brain cells with these enzymes called AADC that takes the levodopa and converts it to dopamine. So that conversion of levodopa to dopamine is really important, and that happens inside the brain. Now, in Parkinson's disease, as you can see, those connections become much more sparse as the cells in substantia nigra die off, and there's hardly any input of dopamine to the striatum or to the putamen. So, in essence, what happens is, now you've got these. This normally functioning nerve cell terminal that in Parkinson's disease, of course, this releases the neurotransmitter dopamine and produces normal responses here. But when these are eliminated, of course, there's no more dopamine. So nothing is happening on the other side of this, which is where which is the downstream area. So the idea then is to introduce a gene or a piece of genetic material with a virus. So this is a non-infectious virus. It goes into the idea of a virus is that it integrates its genetic material into the cells, usually in order for it to reproduce and make more viruses, but these are replication incompetent viruses, so they don't reproduce themselves. All they do is deliver their genetic payload. So this DNA is packed into a virus, and then the viruses are injected into this area of the brain, where they then are taken up into the nerve cells, and the genetic material that codes for this enzyme produces more AADC. So now you've got tons and tons of this AADC enzyme that sucks up all of the levodopa, both inside the body and being given by medication, by Sinemet, and produces much more dopamine. So this is done neurosurgically. So we implant a catheter into the brain, and then the viral vectors, which are suspended in a liquid, are then injected into this area and are taken up into this region. So this is now, the recruitment for this study is ongoing. There are several trial sites in California, UCSF, the San Francisco VA, UC Davis, UC Irvine. So this is an actively enrolling trial for anybody who's interested in learning more about this. So great to hear that about 58% of people are interested in participating in DBS research studies. About 42% saying, no thanks, I don't want to participate in research, which is of course fine. We don't expect people to do so, but many people are interested in it. So if you're interested in research studies, then this is one to certainly consider at least finding more out about. The contact here is Cheryl Chen. This is her phone number, and this is her email. I'll leave this slide up for just a second if anybody wants to copy that down. And of course, as Todd said, this is being recorded, so you can always come back later and get this information if you need it. Okay, another, what I think is a very interesting research study, looks at using near-infrared light as a rescue therapy for the brain. So an interesting property of infrared light is that it can be neuroprotective, which is sort of counterintuitive, and it's still being, people are still trying to figure out exactly why this might be. So this is being run in France, so you'd have to travel all the way to France if you wanted to do this. But what they're doing is they're introducing optical fibers into the brain and illuminating the area of the substantia nigra with infrared laser light. So they've done this in monkeys. It's sponsored by a company called Clinitech. And this is what this thing looks like. So here's the optical fiber. There's a diffuser at the end of it so that the light can diffuse into the brain. Near infrared light diffuses pretty far, so you can treat a pretty large area. And then this laser source is being connected to a standard DBS implant. So a DBS battery with the connector, the laser, all implanted into the brain, into this region near the substantia nigra. And this is showing where that is in a monkey. And this is what the implant looks like in a monkey. And this is the data from the preliminary data, which is really incredibly impressive. So this is something called an MPTP protocol. So this is a neurotoxin that induces Parkinson's disease in experimental animals. So monkeys that have been given MPTP, you can see they have their clinical scores, their Parkinson's scores are quite high. So these monkeys have obvious Parkinson's disease. If they're treated with near-infrared therapy, it turns out that there are two different groups, probably depending on how bad their Parkinson's is in terms of with the neurotoxin. They're either improved by about half or they barely get symptoms at all. So this is just one other way to look at that, where these are monkeys walking around in their home environment. After you give them MPTP, they're frozen. They don't move anymore. They can't move. If you treat them though with this near-infrared therapy, a group of them will be able to move around their home area much better, and some will be almost back to normal. So this is really an interesting and very promising therapy. So we'll see, it's now being translated into human clinical trials, and we'll see how it actually works for people. Another very interesting concept is the idea of stimulating the spinal cord. So this is based on some studies in laboratory animals showing that stimulation of the spinal cord, which we actually use quite frequently for the treatment of sciatica and pain, can improve freezing of gait if you implant it in the region of the spinal cord. So this is what this looks like. Again, it's an electrical stimulation device, a pacemaker device that's implanted in the hip, and then wires or a paddle that's placed in the epidural space. So for those of you who might have had epidural injections for treating back pain, it's the similar sort of approach. It's in this area above the covering over the spinal cord called the dura mater. And then these are the results from an initial study that was run out of the University of Toronto, just showing in 4 patients what the improvements look like. So in walking, step initiation, and stance perturbation, meaning is there any improvement in postural stability? Not really, but there is improvement in step initiation, and quite impressively, improvements in walking. So this is the percent change along the y-axis here. So this patient S4 improved about 10%. This patient improved about 30%. This one, depending on the stimulation frequency, low or high frequency, improved anywhere between 70 and 95%. And this patient had almost a 95% improvement in walking. And this includes both how long it took to walk from one point to another, as well as how often freezing of gait occurred. So this is really interesting and quite promising. And so, this study is now being performed at Columbia University in New York City. They're looking for 10 patients. They're planning to start their recruitment this month. The idea is to participate in the study for 1 year with an estimated completion in 2022. So anybody who's, of course, you'd have to travel to New York for this. So I don't know if anybody's interested in that, but for those who might be interested, this is the contact information at Columbia University for anybody interested in that study or interested in referring other people that you might know for that study. Of course, we've all heard a lot about stem cells and fetal cells. There's a study in South Korea looking at using dopamine, replacing fetal cells that produce dopamine in 15 patients. They started recruiting in 2013 and they're estimating their completion in spring of 2022. So the question, of course, is ongoing whether stem cells or fetal cells are helpful, and will be yet another study that'll help us to potentially answer that question. And the last two studies I'd like to talk about are back again to the topic of DBS, and this is something called adaptive DBS. So we talked a little bit about that Percept device from Medtronic that allows us to sense neural activity. And then, so these two studies look at both the Medtronic Percept or another device called the RC+S, which is a rechargeable with sensing device with that adaptive capability unlocked so that the stimulator senses changes in brain activity associated with symptoms and then adjusts the DBS to compensate. So these are slides helpfully provided by Dr. Bronte Stewart, my colleague in neurology who is running both of these trials. So the first trial is called ADAPT PD. This is a multi-center study. It's prospective, single-blinded, randomized crossover. It's expected to be conducted at 12 centers throughout the US, Europe, and Canada. Stanford is one of those centers, and Dr. Bronte Stewart's the principal investigator here. Of course, the purpose is to demonstrate safety and efficacy of adaptive DBS. It will be automatically adjusted based on sensing of the local field potential. We talked about this, excuse me, beta band power, which is a certain frequency range of brain activity. And this will be personalized. So the DBS will fluctuate within particular safe limits, which will relate to your specific power thresholds. So there will be two different modes that are tested, a single or a dual threshold algorithm. And this is sort of how it works. So again, if we look at recordings from the brain, there are different frequencies that are represented. And this is the power in those frequency bands, meaning how strong those oscillations or the brain waves in that band are. And this just shows that as you increase DBS, so increasing is down, so at 100% of the voltage maximum, you reduce this, this beta power, and thereby it's felt you will likely also improve your symptoms of Parkinson's disease. So here's an example of recording this beta power over time, and then how that DBS changes. Continuous DBS, of course, just stays at the same setting at all times, but the adaptive DBS continuously adjusts the DBS intensity in order to match what that brain recording looks like. This is sort of the study overview. Everybody gets a DBS system implant. They're then enrolled. So this is with the Percept device. So if anyone who has actually had a Percept implanted is eligible for this study. And following implantation, then you're enrolled in the study. There's a baseline continuous phase. The adaptive DBS is set up and adjusted. There's randomization into either a dual or a single threshold mode with a crossover in between, and then long-term follow-up with several different visits scheduled. So this is an interesting study in that it will help us to figure out what the settings could be. Is adaptive DBS helpful? A lot of different things that will tell us about whether or not this is a good way to go. And then finally, Dr. Bronte Stewart is running a single center study called SPRING. And this is looking at closed loop DBS for gait impairment and freezing of gait. So again, this involves the Percept device. The Percept reads the brain signals, responds with therapy, either using normal or long bursts, depending. And then looking at freezing of gait, reading data from motion sensors as well, to try to use this as an input to the therapy. So this is, really a cool study where you're taking both brain signals as well as physical readings and using that to inform how the DBS system is programmed. And this is some of the preliminary results, where off stimulation, what you see here is these are very different steps, and then this represents freezing. So stepping, 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 freezing. This is with the stimulator off. With open loop stimulation, it does help, that those freezing periods become less, but they still occur. But here with the closed loop stimulation, the freezing of gait is practically eliminated. So this was published just this year. Matt Petrucci and Dr. Bronte Stewart's group was the lead author on this study. So with that, apologies, I think I've gone longer than my expected hour, but hopefully it's been interesting and hopefully it's been worth it for everybody. But I'll wrap up by saying that, in my opinion, STN DBS or DBS or GPI for that matter, globus pallidus, can improve all the cardinal signs and symptoms of Parkinson's. Our current generation of DBS systems is really exciting. I think there's, lots of exciting and cool possibilities. I talked about focused ultrasound, which is this new non-invasive potential therapy, working very well for tremor and for Parkinson's. There's a lot of exciting research studies on the horizon with more to come. And for any questions that we don't manage to answer today, or if you're interested in, potentially being assessed for DBS and want to come to Stanford, my nurse manager, Erica Lim, this is her phone number here, is happy to take calls and answer any questions or schedule you for a follow-up visit if you want to come and see. All right, so with that, I think we will take whatever questions we weren't able to answer throughout the course of the talk, and we'll get some feedback as to whether or not people are satisfied if they've undergone DBS, whether they were satisfied with it, didn't like it, or wish that they hadn't done it. I hope that there are a few who are dissatisfied. I hope it's helping more people than it's not helping, because in my opinion, I've seen so many lives changed by it. I think it can be a really great therapy.
Yeah, terrific. That's terrific, Dr. Henderson. So much good info there. And on that line, I really want folks to remember that we will be posting this presentation up on the site and the recording of the presentation on our YouTube channel. So there's a lot of good info, especially in those meaty research study slides at the end there. So please don't freak out and panic, folks. This will be available soon. We do have one other poll. I'll end this one now just so we can see a general response to satisfaction. Fortunately, the good news is the vast majority are very satisfied and glad they did it, with only a few falling into the neutral or dissatisfied. So that's good. I do have one last poll. Oh, I didn't share those results. Now I'm sharing those very results. I do have one last poll that I'll pop up here in a moment that just speaks to folks that have not yet undergone DBS. So just to be clear, we saw at the top with our early poll that several attendees had undergone DBS, and so a lot of these polling questions were targeted at those folks in order to inform those that had not yet undergone DBS and were interested in it or curious about it. So that was generally the dynamic of those polling questions. But the last one here will speak to those that have not yet opted for DBS procedures and what their concerns might be. So I'll post that in a minute, but in the meantime, here, let me just put that up now. But while this is up and running, this poll now on concerns around DBS, Sue and I will dive into some questions. So Sue, when you have a minute, take yourself off mute, but I'll start with one by Karen. So to be clear, Dr. Henderson, DBS is DBS, and then frameless versus stereotactic are the access means to get into the brain and the target.
Correct.
So
That's right.
Karen has a question here that says, are there downsides to frameless? She had DBS at UCSF and doesn't remember anyone telling her about the frameless option. So I can't recall if your slide specifically went into downsides, but if you have a minute to comment on that, that would be great.
Yeah. I would say probably maybe the one downside is for patients, it's probably, separating the procedures like that from the day before to the day after. Some people say they have a hard time sleeping that night, or they're having some discomfort or pain afterwards. With a framed procedure, it's all done the same day. So, there isn't that overnight period. So that's, for the patient, maybe, it's hard for me to assess whether or not the increased comfort with the placement of the markers compared to a frame is offset by the discomfort in the overnight area. But for me, I think it's been, for the surgeon and for the team, it's clearly better in terms of being able to have that time to do the planning without the pressure of having an open operating room and people, and knowing that you have to get everything planned up. There's just a completely different feeling to relaxing at a workstation, planning the operation, as opposed to we got to get going, we got to get going, we got to get going. So, I think those are very, other than that, I would say, I think they're comparable, and I think in skilled hands they are both equally accurate.
Got it. Good. Thank you.
Okay, here's a question from Andrea. I've had movement symptoms for 5 years and can't use dopamine agonists or levodopa because I can't tolerate the side effects. How early can DBS be used? And also, she's read that DBS causes more cognitive impairment for people with GBA variants. Do you know anything about that?
Frequently, DBS is, there's a lot in that question, so let me unpack it just a little bit. The DBS can be used reasonably early on, and a lot of it also depends on your particular type of Parkinson's disease, your age, etc. So, for example, those with young onset Parkinson's disease almost surely will develop side effects at an early stage. With medical treatment, will develop dyskinesia, dose failures, etc. So in my opinion, those with young onset Parkinson's are excellent surgical candidates, which is not to say that older folks are not good surgical candidates as well. It's just that the sort of the optimum range is in that younger time frame. There have been studies looking at instituting DBS as early as 3 years after diagnosis, and it can be effective at any of those ranges. My own personal opinion is earlier is probably better. So, I would say, in my opinion, I don't know that there would be a downside for looking at DBS in an early phase. I would definitely want people to go through, a trial of medication, because that serves many different purposes. For one thing, it really establishes the diagnosis of Parkinson's if you're responsive to levodopa, because that's an important aspect of it. So also, we want to be sure that you've tried things before you go ahead with DBS.
Mm-hmm.
So
I popped the poll result up there for you to see, just out of curiosity.
Oh, great. Oh, yeah. Okay. So, yep, for those who have not yet undergone DBS, lack of knowledge, hopefully we've helped with some of that today. Insurance or costs, Medicare covers this. So, normally that should be covered. Pain and discomfort is something definitely is of concern with any surgical procedure. We try to do the best we can to manage that. And, you know, any other health problems, of course, could make things more potentially complicated.
Right. The best news there is that 18% of respondents say they're not worried about anything.
Okay.
Second best news is that lack of knowledge is slowing them down, and that's exactly why we have webinars like this. So let me go ahead and stop that, and we'll keep going back and forth between Sue and myself on questions here. I do have one here from Gerald. I know Gerald through the Pediatric support groups. It's a neat but serious question around small motor coordination. And I'll share this question with him because Gerald's a guitar player and wants to know if DBS will improve the small motor coordination around guitar playing. Gerald's going to be the lead guitarist in the Pediatric band that we're going to form soon, and I'll be the drummer. And I'd like to know if DBS would help with my coordination of my left hand on the snare that's just not responsive. So I've got, you know, coordination, small motor skill issues with my hands that are preventing me from playing the drums. What can you tell us about that?
Yeah, but of course, you know, we can never make any guarantees or promises, but the likelihood is yes, it would help those things.
Great. Phew.
Anonymous has a few questions. Of all the procedures are done with the patient awake, good Lord, why? This would seem to be torturous. I mean, you're cracking into someone's skull. Although your video probably explained this, maybe you could just comment on it
Sure.
for us.
Yeah, so, you know, in fact, one doesn't have to have the procedure done awake. That's it's not an absolute requirement. I've done many procedures asleep. So there's differences in the technique between the awake and the asleep procedure. When you're asleep, we have to have some sort of way to verify that we're at the appropriate target. And so we'll usually use some form of imaging. And my preferred technique is to use an intraoperative CT scanner. It's a portable CT scanner that we roll in and check to make sure that the leads are in the right location. This seems to work pretty well. And I think people who do, and I think people have pretty similar outcomes. My own preference, and many patients actually prefer to have it done awake. And the reason is, good Lord, why? And the answer is because it gives us real-time verification of whether we're in a spot that's going to be helpful for you and whether it's going to provide, and whether or not you're going to have side effects there. So the main thing is side effects. We want to make sure that when we turn the stimulation up, well, two things. First, we want to do that very precise mapping of the region, and we, you know, need you awake in order to cooperate with some of those tests. So number one. Number two is we want to make sure that when we do the stimulation that we have minimal side effects and that we have some benefit. Now, we don't look for great benefit necessarily during surgery. We just want to, you know, make sure that it's not going to harm you. And then we can always tune it up later. If we know that we're in a good location, if we know we're not having bad side effects, then we're pretty confident. Whereas if we're, you know, if we have an imaging confirmation, we're also pretty confident, but less so because it's not functional. So hopefully that answers the question.
Unrelated follow-up.
By the way, I'm sorry, Sue, I'm sorry to interrupt. Last thing is, during the drilling procedure, we try to have people asleep. So we'll do the first part of the procedure under sedation. Then once the holes are drilled and everything's set up, then we wake you up for the part where we want your cooperation. And then we make you sleepy again towards the end, you know, for the closure part. So we try to make it as comfortable for people as possible.
That sounds like a good plan. Another anonymous person, or perhaps the same one, asked, how do you live day to day with all the stuff attached to your skull, embedded in your chest? How can I still jog, play golf? How much is one limited?
Yeah, so, you know, in general, the limitations are very few. You know, we've had people go back to a fully active lifestyle. You know, I usually tell people to refrain from skydiving and tackle football and that sort of stuff. But, you know, most normal activities are just fine. You know, I'd say, you know, the majority of people do really well. One thing that some patients get is something called bowstringing, where the wire that runs down the neck can get taut. Thankfully, it's not terribly common, but it can be uncomfortable. And what I tell people to do as a preventative measure is during recovery, just continue to move your neck back and forth a little bit and stretch that out, even if you feel some discomfort there, to keep that scar tissue from forming. So, but that's, apart from that, not terribly limited.
And I'll chime in just to be clear that once the procedure is done and the target has been accessed by the probe, the frame comes off the head. You're not walking around
Right.
Day with the frame on your head.
Absolutely. Yep. No, when everything is done, it's all implanted. It should be pretty, and you can see a bulge in the chest where the generator is, and there's a little bulge here, and where some of the hardware is, but it's pretty unobtrusive for the most part.
Right. But heaven willing, our hair grows back and you're not even seeing the bulge or the.
Exactly. Yes.
Good.
Well, for me, it probably would be visible. But
Brain might have left that station. Huh? I've got two questions from another friend from PD Active support groups, Prob. Prob asks, is there a shelf life for the devices? And might there be any negative long-term consequences of the devices not functioning?
You mean in terms of, so I think what the question is, how long does the device last? How long does the battery last, for example? And that's normally 3 to 5 years for the non-rechargeable ones, for the Medtronic ones. And so at the end of that time, another operation is required in order to replace the battery. So we take the other one out, put a new one in. It's the entire unit is replaced. It's a very short procedure, only takes about half an hour, and it's done as an outpatient. For the longer lasting ones, the rechargeable ones, we usually don't have to do that for many years, up to 15 years.
Okay. And the probe has got a lifespan, I imagine, or no? No,
the DBS electrodes, I've had patients with those in for 20 plus years. So it's, the systems are quite robust. And it's very, very rare to have any sort of breakage or any other problem like that. I've had maybe a couple of those, but they've been very specific, that we've had lengthy. I had one fairly young person who was a dancer who, had a very long extension, and the pulse generator was implanted in the pelvic region, just for cosmetic reasons. I've only done that once because that just was a bad idea, because it broke, because, in a dancer with a long length of wire moving around, right. That's just asking for failure. But in the normal location, everything works pretty well, and it's very, very rare to have any sort of breakage or malfunction.
Good. Related question from Prob is, any concerns to the heart regarding the placement of the pulse generator?
So we normally put the generator on the right side in order to, if one ever needs a pacemaker, you can put one on the left. But no, because it's underneath the skin, just over the pectoral muscle. So it's, it's all well away from any cardiac issues.
Adam from our board has a question. If a close friend came to you with a recent PD diagnosis, what would you recommend?
Yeah, well, that's a great question. So this actually just happened to me. I did have a person who was recently diagnosed with Parkinson's disease. So, there's sort of a progression of things that one should do. First, see a good neurologist. That's number one. So be sure that you're hooked up with somebody who knows movement disorders. There are many neurologists in practice who treat a lot of movement disorders patients, and I would consider them experts. Or, there's also, of course, academic centers like Stanford where we have people who do nothing but movement disorders neurology. So definitely get hooked up with somebody who knows how to treat the disease. I would start on some medication, and again, it would depend on the individual what medication that would be. I personally don't haven't prescribed meds for years. I let my neurology colleagues handle that. But I wouldn't really be thinking about surgical options at first. It's important to establish the diagnosis. It's important to get on a stable regimen. It's important to get established with your medical care. And then as time goes on and as it becomes more evident the course of your disease, that's the time to start thinking about surgical options. I would also, importantly, continue to exercise, continue to lead as healthy a lifestyle as you possibly can. Get hooked up with PD Active for sure. There's another another foundation called the Davis Phinney Foundation that's really invested in living a healthy lifestyle with Parkinson's, living with Parkinson's. So there's lots and lots of things that you can do outside of medical and surgical things that can also be helpful. So I would do all of those things are the recommendations I would have for somebody who is newly diagnosed. But despite the efficacy of surgery, I probably wouldn't use it in the very, very early going.
Thank you for answering that. Also, I'm sorry, Todd, why don't you go ahead?
Sure. I just want to do a quick time check, Sue, and then I'll give you your question. It's 8 minutes after noon, Dr. Henderson. We've got plenty more questions. So if you're okay with another 10 minutes or so, will that work for you?
Absolutely. Yeah, I want to try to make sure everybody gets their questions answered.
Good. Terrific.
That's why we're here.
And go ahead, Sue.
Is Dr. Helen Bronte Stewart still working on transfusions of young adults' blood to elders to reverse aging? Might this help Parkinson's patients? This a question from Douglas.
The Fountain of Youth question.
Yeah, no, great question. That's an interesting concept, and that has been explored in animal models here at Stanford. I don't know where that stands clinically. I'm sure it's probably not. I don't think it's close to being something clinical yet, but it's a really fascinating research question. Stay tuned. One of the ways you can stay on top of research studies is there's a website called clinicaltrials.gov. That's the website is that just spelled out clinicaltrials.gov. And you can go into there's a search engine there. You can type in Parkinson's, you can type in surgery, transfusion, all sorts of search terms, and you can keep up to date on all the different studies that are ongoing. So I'd recommend that for those who are interested in that type of thing.
Thank you.
Clinicalstudies.gov. Is that what you said?
Clinicaltrials.gov.
All right, I will make note of that and share that. A question from Gary, which might be Dr. Gary, given his question. Is DBS neuroprotective against further decline or death of dopamine-producing brain cells?
That is a great question, and it is one that has been debated back and forth. There were a series of studies performed, I don't know, about 10 years ago or so on rats that were suggestive that DBS could be neuroprotective. I don't think they've ever been replicated to my knowledge, and it's still unclear. I would say my own opinion of how DBS could be neuroprotective is that Parkinson's disease affects the basal ganglia, which are a set of structures deep inside the brain. Now, those are intimately tied in with an area called the cortex, which is the thin rim of brain tissue that's in the folds of the brain. And those two things work together. The basal ganglia send their output to the cortex, which then sends its output to the muscles. In my opinion, the cortex is a very flexible, well, it's not just my opinion, it's true. The cortex is a flexible learning machine. So when we learn a new motor skill, we learn it using our cortex and of course our basal ganglia too, all working together. But in my belief is what happens is that you've got this machinery that's producing this Parkinsonian abnormality feeding into the cortex, which is still normal. The cortex hasn't been affected by that, by these chemical imbalances. And so the cortex learns how to be Parkinsonian, essentially. You've given it input for a long enough time that it learns that abnormal input. And so the earlier you can intervene with DBS, the sooner you can arrest that process of learning that occurs in the cortex. So again, never been proven. That's just my own particular opinion on how DBS might be, about how earlier DBS might protect you from more rapid decline later on. So further work yet to be done.
Great. I've got one here from Karen again. One of your slides was illustrative of how the probe could be steered into its target on a sort of a symptom by symptom basis, freezing of gait, shuffling gait, etc. Karen asks, is there a way to steer the device to minimize a symptom like double vision?
Absolutely. That's exactly what it's designed to do. So, double vision occurs when the stimulation field is getting too far medial or too far toward the midline. And so by steering it away from that midline and out more laterally or towards, toward the outer part of the brain, you should be able to reduce the double vision. So that's what, that's what a device like this is really good for.
I have a question from James concerning the tremor. How do you determine whether the tremor is PD or due to other Lewy body ? Reasons?
Well, yeah, so that's a difficult call to make. We can pretty easily distinguish Parkinson's tremor from essential tremor. Essential tremor being an action tremor, being usually faster. Parkinson's tremor is slower, usually occurs at rest. And of course, Parkinson's tremor is associated with some of the other effects of Parkinson's. Differentiating what Lewy body disorder or other what we call Parkinson's plus syndromes is much more difficult and requires detailed examination by an experienced neurologist, and often just kind of time to wait and see how things evolve over time. They can look very similar.
Great. So you got another?
Yeah, the question came up about the drug Azilect and what is its role?
I'm going to defer that to my neurology colleagues who are, I would say, much better at answering drug questions. I'm happy to answer anything regarding surgery, but I'll defer the drugs to my neurology colleagues.
Yeah, that's a question that's a little bit higher up the food chain of the disease. Here's one, and maybe this will make this our last, Sue, unless you see any, but back to the discussion around targets of the stimulation probe. What are the pros and cons of different targets? And I think I can guess the answer to that. But the next question is, why is STN the target you use most often?
Yeah, no.
Maybe you could start with reminding us what STN stands for.
Sure, yeah. So the two main targets for Parkinson's are STN, which means subthalamic nucleus, and GPI, which means globus pallidus internal portion. The GPI was the original target for Parkinson's. They're both part of this network that's affected by the lack of dopamine in Parkinson's disease. And oftentimes I'll put up a slide that illustrates this. The problem is it's a little complicated and kind of boring, I think, actually, sometimes, to go through all the different arrows and what affects what and what makes each area, hyperactive versus less active. But the bottom line is both the GPI and the STN become hyperactive in Parkinson's disease. They have slightly different connectivities and slightly different actions. So the major difference between STN and GPI is medication reduction. So by stimulating STN, you can often reduce medications, whereas by stimulating GPI, you usually have to stay on the same dose of meds. GPI will help reduce dyskinesia. It'll do many of the same things that STN will do. Now, that being said, I would say that both targets can be very effective. Part of the reason why I favor STN is that it's a smaller structure, which means that if you target it precisely, you can get you can stimulate a bigger portion of it to get better side effect or to get better symptom reduction with lower voltage than you can with GPI. So your batteries last longer. So there's a whole host of reasons why STN has become my preferred target. I've done GPI on some patients. And how do we choose between STN and GPI? So for people who are cognitively normal, who we at Stanford, we have people undergo pretty extensive neuropsychological evaluation. And for those people with normal function, STN is what I prefer. If you have some reduction in your cognitive capacity, so if there's some indication that you might have more confusion or word finding difficulty or other types of cognitive problems after surgery, then we might consider GPI as the target. But just for the most part, we've just had excellent efficacy with STN, and that's my favorite target. So hopefully that explains it. I think there's a lot of individual surgeon and neurologist preference. So and the question's completely unsettled as to whether one is better than the other. There have been a lot of comparisons, and nobody's ever come down and said, this is clearly the superior target to the other.
Got it. Sue, I do see one or two other questions in our chat tool here. So let me grab one or two of those and then we'll wrap.
Okay.
Dr. Henderson, does DBS affect or improve pre-existing psychiatric conditions or the non-motor?
No, unfortunately, that's where DBS doesn't help. Non-motor symptoms like any neuropsychological, cognitive problems, no, it doesn't help speech usually. I've had some patients who just in general, their volume may get a little bit more just because they have generally, if their speech improves with medicine, then it might somewhat improve. I use that as sort of a rule of thumb. If it improves with medicine, chances are good it'll improve with surgery. But any psychological or psychiatric problems, no. And in fact, there can be some worsening depression with DBS that we have to really look out for as well.
Interesting. Okay. And related, are there, well, we just covered that, so let me skip past that. Can DBS surgery or the electrical signals make cognitive decline more likely over time? So other than potentially negative repercussions around depression, what about the cognitive side of things?
It's a tough question to answer. We tried to answer this question a few years back by looking at patients who had undergone DBS, doing cognitive testing before and after, and people who hadn't. But the problem was that, to do detailed cognitive testing is pretty time consuming and difficult. And people don't want to do it. So, we enroll them in the study, but then they'd say, I just don't want to do that other neuropsych test. So we just couldn't get enough data. So unfortunately, it's still an unanswered question as to whether DBS improves or worsens cognition over time with comparison to just best medical management. So I can't answer that question. I know there's, looks like I'm sort of been monitoring the chat too, and it looks like Andrea has been asking about cognitive impairment for people with GBA variants. This is that's interesting. I haven't heard about that, and I don't know about it. So that's interesting. I will look into it.
GBA standing for?
I'm sorry.
GBA meaning?
These are different genetic variants of Parkinson's. It's a very subtle and learned question. So she must have been reading about it. So I personally am not aware of it, but thanks for alerting me to it. I'll look into it. And I don't know that we necessarily test people for different GBA variants here at Stanford.
Interesting. Well, I'm glad you're eavesdropping and lurking on that chat window. If you see any others that you would like to jump on and answer, please go ahead. Sue, do you have any others that you're keen on?
No, I think I'm good. Looking at the list.
Okay.
Maybe I'll take one last one.
Okay.
Which is with 3 reputable companies marketing DBS units having differences in their technical approach, what's the best process and key factor for deciding which unit to adopt? That's a great question. So the algorithm I've used is quality first. So I've had experience with all 3 of these companies through many different iterations of devices, mainly in the pain world. Actually, I've done pain treatment for my entire career, and all 3 companies have made pain devices as well. So quality-wise, that's why I've settled on Medtronic and Boston Scientific, having worked with those companies and been impressed by their quality control. It's frankly the reason that I have not necessarily used the Abbott devices, because A, I don't think they provide any benefit when compared with what I can get from the other 2 manufacturers, and B, I don't believe their quality controls is good. So that's the reason that I'm not a big fan of Abbott. So that comes down to Boston and Medtronic. And it's an interesting discussion that we have with patients. And when we're deciding on an individual manufacturer for an individual patient, we go through probably 15 or 20 minutes worth of discussion we have examples of the devices, physical examples. We talk through the pros and cons, and it's a shared decision between patient and surgeon. So in general, we've probably done about 50-50, where some patients really like the idea of the Medtronic Percept and the sensing and the future of closed loop stimulation. Some people really like the Boston Scientific because of the rechargeability and the steerability and other things. It's really individual. So it's, I think the short answer there is we've got two great manufacturers, and between those two, we decide together.
Got it. Well, there is one last comment that we need to share, and that is from Lauren, who says, Dr. Henderson performed DBS on me October 28th, and my second surgery was November 10th. He is fantastic. So on that note, Dr. Henderson, let's put a bow on this and start by thanking you once again from the bottom of our pediatric hearts and DBS stimulators. We really appreciate your spending some of your valuable weekend time with us. You're super experienced with over 800 DBS surgeries, and so your knowledge comes very valuably to us. So thank you very much. We really appreciate it.
My great pleasure. I really enjoy talking about this stuff with everyone. So thanks everyone for attending.
Good.
Thank you, Dr. Henderson.
We still do have about 40 of you online, and I'll just put out one last request that if you haven't yet had a chance to make your $10 donation for the program, please do so. That is again pediactive.org/donate. And that is all. Reminder that we will put this up on the Pediactive.org site and our YouTube channel. Otherwise, I hope everyone has a wonderful rest of your weekend. And Dr. Henderson, you especially.
Thanks.
Thanks, everyone.
Bye, everybody.
Bye.